Dr. Vogelzang is our first speaker on chemotherapy. I wanted to come up here. I am not big on introductions. We have an elaborate CV in the program. I just like to add a personal note. I would rank him as one of the top oncologists in the world. It's that simple. I've known him for 15 years. He is one of the most knowledgeable people on prostate cancer I've ever met. He's actually a cancer survivor himself. He's practicing actually in Las Vegas. He's worked with every major group you can think of. And so he's really the go-to guy to speak on this subject, and I couldn't be happier that we're starting off the conference this way.
Yes,
thanks.
Well, you know, it's fun to be here. Mark has been telling me about heart healthy, prostate healthy for many years. And as I've gotten more and more into earlier stage prostate cancer and less late stage prostate cancer, I'm beginning to see the relationship between obesity, heart disease, diabetes, hypertension, hypercholesterolemia, and prostate cancer. So now I feel like I'm becoming Mark Moyad II. And so now when somebody comes up to me and asks me about pomegranate juice, I say, well, what brand is it? Mark, you know, you've distorted me. I used to be able to talk about chemo. Now I talk about diet. But the reality is that there are still 30,000 patients a year who develop metastatic hormone-refractory prostate cancer. And so I'm going to bring us to the very cutting edge of new treatments for this disease. And I'm going to try to do it in a fairly straightforward way. There's a fairly simple problem that has not yet been overcome, and that's illustrated on this slide from quite some time ago. And that is that prostate cancer remains heterogeneous. Heterogeneous means that within the genomic substance there is the ability for the cells to mutate. Although the metastatic cancer, the cancer that grows into the bones or the lymph nodes of the lung or the liver, may be somewhat similar to each other, within each subset there are clones. And the clones are shown in this case in white. If white is hormone sensitive, then hormone sensitivity is retained throughout the natural history of prostate cancer. It's for this reason that we recommend continued hormone therapy, continued Lupron, surgical castration, the use of secondary hormones. There's even been some people who think that maybe we should never let up on the new drug abiraterone because it does suppress prostate cancer growth in many respects. So the heterogeneity we have not yet overcome. And this is strikingly illustrated in patients with other cancers. For example, melanoma, which is normally a black cancer, will sometimes show white metastases. And those principles have been long known in other cancers. We tend to forget that in prostate cancer. We tend to think of it as a monolithic disease, but in fact it is not. It's for this reason that I use this slide to remind us all that we still have to think about hormone therapy, even though we may be trying chemotherapy and other things. Well, here are the current, excuse me, here are the current landscapes for what we call castration-resistant or hormone-refractory or androgen-independent prostate cancer. I'm not sure any of those names fully capture the complexity of the disease, but nonetheless, we have what we call palliative therapies, and that means that we cannot prove that the use of those agents improves overall survival. Although the secondary hormone therapies are commonly used, and in fact, a recent paper from Harvard showed that the average time on secondary hormone therapy was 4 years. The average time on primary hormone therapy was 2 years. So clearly the secondary hormone therapies apparently have substantial effect in these patients. But we have been unable to show that secondary hormone therapies improve survival until the press release this past week. Who read the press release about abiraterone? I'm not seeing any hands go up. So abiraterone improves survival. How many people knew that? Nobody. Okay. Well, I guess I get to be the water bearer. abiraterone has just had its code broken in the Cougar 301 trial, and it improves overall survival. A dramatic breakthrough which will be soon announced. So the secondary hormone therapies will now go from palliative to a survival benefit. Secondary therapy with external beam radiation therapy has long been used, and we do it to treat the areas of the bone that may have painful or uncontrolled growth. That's a good example of the clonal nature of the prostate cancer. So let's say that a particular clone, in this case the yellow, is painful. Well, you can sometimes radiate just the yellow area when it's in one bone or in the chest or in the rib or in the spine, and you can improve the outcomes of those patients. So it may be that external beam helps. Bone-seeking isotopes are helpful. It's like samarium, strontium, and we have a new one from Norway called alpha radon, or radium-223. That's quite different. It's not a beta emitter. Who knows what beta particles are? Let's see the audience. A number of you know the beta. Okay, how many understand the difference between beta and alpha particles? Good. The engineers do. Congratulations. Can you educate the guys around you? The alpha particle, which I learned at Argonne National Laboratory when I was a student, goes very short distances, but is very powerful. It's why you take a shower after you're exposed to nuclear fallout, because it'll burn your skin. And the alpha particle can be given intravenously. And that may be a new step forward. The trial, the phase 3 trial, and to listen to Dr. Moyad, not to say something about promising, but the phase 3 trial is accrued to 690 patients. Is due to go to 900 patients. It's randomized against placebo, so patients can get either the alpha radon once they have painful bone metastases or placebo. But the nice thing about it is it's designed by smart people, and that means that I can do anything I want on the placebo arm as long as it's not chemo. So that trial is coming along well. Bisphosphonates, we'll talk about that in the next section. Mitoxantrone, we'll talk about that in the next section or in the next piece of the talk. And then two major important factors were new data, and that's the Sipuleucel T, which I'm not going to spend a lot of time on because there's a full session, and cabazitaxel, the new agent in the post-docetaxel setting. So let's go through what happened at ASCO, American Society of Clinical Oncology, this past year. It was in May or early part of June, and this was a trial that everybody was rather disappointed in. The reason they were disappointed is because we all, I included, thought this was going to be a major breakthrough. Docetaxel prednisone was the standard in blue, and docetaxel prednisone and the Avastin compound was in yellow. Now, you may have read the news about Avastin being withdrawn from approval for breast cancer, but make no mistake about it, this is a powerful drug, and it has anti-cancer activity of a significant nature. So we were optimistic that it would be helpful in prostate cancer that was metastatic. And in fact, as you looked at the preliminary results, there were signs that it was quite helpful. It improved the response rate from 42% objectively to 53%. There were greater numbers of PSA declines, and the time that patients were able to stay on the drug went from 7.5 to 9.9 months. But it didn't quite squeak over the finish line far enough ahead of docetaxel. It came over at 22.6 months versus 21.5 months, and that was not statistically significant. Why was that? Don't know. Could be that we are getting better at treating prostate cancer and that more patients got additional therapies such as cabazitaxel, or et cetera. But be that as it may, this came close, but as they say, no cigar. The drug Avastin was more toxic, and therefore this also diminishes our enthusiasm for this compound. It caused more blood count problems, more hypertension, more intestinal hemorrhage, more thrombosis, although not a lot. There was definitely increased death rate from that drug, and so it did not significantly increase what we call OS, or overall survival. It did, however, significantly improve other outcomes. So for patients who are in extremis, having a lot of pain, whose disease is in the liver or in the lung and causing symptoms from that, this may be a reasonable thing to try, but it does not improve overall survival, and it causes more severe toxicities. Interestingly, there were more deaths in the Avastin, perhaps due to some negative effect on the immune system. That is an area to be looked at. Another attempt to improve upon our standard of therapy, which is docetaxel, again in blue, was addition of a vitamin D type compound called calcitriol. And this trial was reported out about a year ago in a press release. It led to the closure of the company that had the drug. The company was a one-trick pony, basically. And when the press release came out, company shut down. But it now is being reported in full detail. It's called the ASCENT-2 trial. And to quickly summarize, there were more deaths and less survival when this high-dose vitamin D was added to the weekly chemotherapy. Now, everyone would go, oh my goodness, vitamin D was worse. It caused poorer survival. But Dr. Scher and his colleagues went to great lengths to dispel that notion. Rather, the issue seems to be that the weekly use of docetaxel was the culprit. And if you look at all the outcomes, there were no side effects that could be attributed to the high-dose vitamin D. In fact, it did appear to be less toxic, as evidenced by what we call serious adverse events, 33% versus 34%. So this is a little bit of a complicated slide, but to quickly summarize, the tax or docetaxel Q3 weeks, the bottom slide, I can't point it out real easily from here, but in any case, that number, 335 with a median survival of 18.9 months, has slightly improved over time. You just saw the Kelly trial, which was 22 some months. So we've gotten better, but the weekly dose, where it says tax QW, 17.4, we have now seen this repeated on several other trials. That every week chemotherapy is not the way to go. And that's the take-home message. So calcitriol with weekly chemotherapy was associated with a shorter survival time, and this survival effect is likely due to the weekly chemotherapy. Therefore, weekly chemotherapy is not recommended. But the high-dose vitamin D compound did neither protect nor reduce toxicity particularly, which is, again, a disappointment. So two sort of important principles. I'm going to briefly run by the Sipuleucel T. I think Mark's already mentioned it. The whole issue of T-cell immunotherapy is very exciting, reminding you that this is a delayed effect. The infusion of the activated dendritic cells in turn has to activate the T cells. In general, the T cells are the killer effector cells, and they take a while to wake up and to become active. So what we see is we don't see an immediate effect, and there are very little ways that we can do to prove that this is immediately effective. The study was called IMPACT, 512 patients, and here are the survival outcomes in the 3 randomized trials. So there have been the large trial of 512 patients called IMPACT, and then two smaller trials, one of 127 and one of 98 patient trial. And if you look at the difference in median OS, median overall survival, you see a consistent effect in favor of the Sipuleucel LT in each disease, in each trial. So it's the weight of the evidence. And when Mark and I went to the FDA independently, we had the D9901 and the D9902A studies, and the FDA said, we're not convinced. In retrospect, I guess they were probably all right to say that, although we could argue it. But with the IMPACT trial, they were forced, and we have the data now. Side effects are pretty manageable. Chills, fever, headaches, influenza-like symptoms, mildly increased. Pretty well tolerated. Virtually no one has any need for hospitalization or any additional treatments other than Tylenol and some Benadryl. And it's now ready to be given, and we're actively giving it. Mark and I are among the larger users of the drug in the United States. Now, the other new drug that is FDA approved that has a survival advantage is cabazitaxel. I wanted to spend a little time at this. This is a tree bark derivative, again, a taxane, but it has been modified through the powers of chemistry to be resistant to the cell pump out effect. So our cells, well, not all of our cells, but many of our cells protect themselves from these compounds by pumping them out. They can diffuse in, but they get pumped out. And this compound is not pumped out. It's pretty cool. It stays in the cell. And it means that you can kill cells with this compound that are otherwise found a way to get rid of the cancer chemical or cancer-killing chemical. This is the same mechanism, though, as docetaxel or Taxotere. It's not a dramatic, different way to attack cancer. It is simply a way to overcome one of the tricks that cancer uses to become resistant. So it has activity against a wide variety of cancers, and it was studied in a phase 1 trial where it was effective in an earlier dose schedule from San Antonio. So the Sanofi Aventis took this drug and compared it to the blue standard. So the standard was mitoxantrone, otherwise known as Smurf juice, because it's purple. And the mitoxantrone was a standard that was not overwhelmingly positive, but at least everyone could accept it as something to do if docetaxel was no longer working. So the patients were treated in a 1-to-1 ratio, 755 patients. Most of these patients were treated overseas, a few in the United States, or some in the United States. But the drug came sort of out of the blue because none of us in the United States were really participating in the trial. We had made other commitments to do clinical research. And I'm sorry for this busy table, but the cabazitaxel was better than mitoxantrone or Smurf juice at most of the levels that we looked at, 14% versus 9% in terms of tumor shrinkage. PSA dropped 40% of the time versus 18% of the time. Pain was not different very much, although I must say my experience so far has been that pain is quite nicely alleviated. I'm not sure if they captured pain in the correct way. Many of these studies do not ask the patients, surprisingly enough. You would think they would ask the patient, but not often do they do that. So I'm always skeptical of these kind of studies unless the patient reported outcomes or PROs are part of the study. In any case, the benefit was primarily in terms of the shrinkage rate, the PSA decline, and the overall survival was about a 3-month advantage in favor of this new drug. And these data were balanced by some extra side effects with low blood counts, with some diarrhea, 47% diarrhea in fact, and some fatigue. There was greater number of deaths. So what we've done to sort of prevent some of these side effects is now all patients getting the cabazitaxel get a white cell count booster called Neulasta. And that has, at least in my first dozen patients or so, has completely eliminated the low white blood cell count problem, and in turn has given no diarrhea. So I don't know what the linkage there is, but it's like most things in medicine or most things in engineering. When you get something, you can tinker with it and make it better, and that's what most of us are doing, making it better. So this study, known as TROPIC, showed that cabazitaxel prednisone significantly improved overall survival compared to mitoxantrone, and it had a lot of other benefits, such as longer duration of benefit and greater numbers of tumors that shrank, although interestingly it didn't, at least according to the technology they used, didn't improve pain outcome. So it was the first drug to show a survival advantage in metastatic prostate cancer after being treated with docetaxel. So we now have, like in breast cancer, we have a second line of therapy. Now, for those of you who know a little bit about breast cancer has 5 lines of therapy. Prostate cancer has 2 lines of therapy now. So we're still not caught up, but we're getting there. So this report that came out in March or April was confirmed, and the FDA looked at this and rapidly gave approval. So we had this drug available by June 17. So Mark comment about Sipuleucel LT and Provenge being available on April 29. I view June 17 also as a very important date for prostate cancer patients, because this was another option that became available on that date. We have some warnings to be careful of. It is allergic reaction. It's from tree bark, so it has, or tree roots. It's got some allergic risk. We have to give it with steroids. We do have to watch the white blood cell counts, and yes, we do have to always be careful when we give this drug. Now, there's been I mentioned at the beginning that abiraterone showed a survival advantage, and I noticed that no one in the audience had yet read this. So I'm just going to cover briefly this class of drugs because they're coming rapidly. In prostate cancer, if you remember the white cells, those would be the white cells that continue to have the need for testosterone to make them grow. And it's for this reason that we give Lupron or Trelstar or Zoladex continuously. We don't ever get it up because we're afraid that if the testosterone rises, those white clones will proliferate and cause increasing problems. So that knowledge has led to this knowledge that there are cancer cells that are white. They continue to need androgen receptor amplification. In addition, there's been new information to suggest that the cancer cells themselves produce testosterone. Holy cow, what a smart-ass tumor. It's a remarkable thing, and it came out of some work from Jim Moeller at Roswell Park in North Carolina, and it's been confirmed at Harvard that low levels but active levels of testosterone and its compounds are produced by the cancer cells. So there's also ways that the testosterone electrical circuits. You know, there's a whole electrical circuit that follows downstream from testosterone and its binding proteins, that this electrical circuit can be activated by other compounds. And we've known that for a long time. So these alternative pathways, or sometimes known as outlaw pathways, continue to be of interest and may allow us to find a way to treat this cancer better. So last year I was able to tell you a little bit about MDV 3100, and this MDV 3100, shown in the yellow or gold or whatever color that is, inhibits a variety of the steps in the electrical circuitry downstream. So again, it's hard to, no, I can't reach it with my yellow, well, I guess I can. There it is. I'll try it. It doesn't work well. Forget it. The yellow MDV 3100 blocks the androgen receptor. The androgen receptor is shown in salmon, pink salmon. So this whole system is quite susceptible to manipulation with drugs. So the AR, salmon colored, we can inhibit heat shock protein, HSP, because HSP is like the guardian. It's like the bodyguard of AR. It's the guy who packs heat for AR. It says, get out of my path to anybody that wants to inhibit AR. And we have new drugs that will be inhibiting HSP soon. Meanwhile, MDV seems to displace HSP, allowing us to block AR, and ultimately to inhibit the mechanism by which testosterone stimulates growth. MDV is able to shrink tumors that are both chemotherapy pretreated and not pretreated. These are data that were published just the beginning of this year in Lancet. PSA decline rate occurs in 50 to 60% of all patients treated with this drug, usually for about 30 to 40 weeks. It's not a panacea, but it does delay, prolong, and ameliorate the prostate cancer. It also knocks down the circulating cancer cell number, which we think is a good surrogate for survival. And if you look at the bottom line, it says unfavorable baseline CTC count. Converted to favorable, that means that you go from above 5 to less than 5. For example, one of my cabazitaxel patients last week went from 80 to 0. That's a good thing. And it is important for this sort of drug to be able to do that. And it does that. And those are all statistically significant. This drug is moving along quickly and will, we hope, be available in around 2010 or thereabouts, 2012 or thereabouts. The drug side effects are quite minimal compared to the chemotherapy side effects. These secondary hormone therapies are quite tolerable, although at the higher dose levels, as I mentioned several years ago, there is a risk, at least in 3 patients, of seizures. So we have to be careful with the drug. We don't know why the seizure does occur. The drug that has gotten FDA approval, or will hopefully get FDA approval now that it has the survival advantage, is abiraterone. Excuse me. My teenage son went back to school, and I think he brought back some viruses. Abiraterone is now going to be FDA approved, we believe. It effectively inhibits an enzyme that makes testosterone out of cholesterol. So one of the reasons that we think that lipid-lowering agents such as Lipitor and Pravastatin, by the way, how many of you are on Lipitor, Pravastatin, or Simvastatin? It looks like a big chunk of you, maybe 50%. Those actually may prevent prostate cancer, or at least decrease the risk of prostate cancer. And possibly through this mechanism, because you lower cholesterol levels, and that is a feeder of testosterone. Abiraterone is a much more potent inhibitor of the synthesis of testosterone. And in fact makes testosterone become zero, provided that you start at a low enough level, and that's why you have to take this drug with Lupron, or with whatever LHRH agonist you happen to be on. Here were the two studies that led to the big phase 3 studies. You've probably seen this already. PSA declines in the chemotherapy naive and in the chemotherapy pretreated patients occurred in about the same rate as MDV. Tumor shrinkage did occur, and the average duration of benefit was somewhere on the order of 9 months. Side effects, because of the blockade effect on the steroids that we use for stress, do cause a mild degree of hypertension. So hypertension is an issue, and you got to take this drug with a little bit of prednisone, 5 milligrams twice a day. So this drug, and I'm not going to try to extrapolate because the FDA will have to deal with all these big phase 3 trials. But there's 2 phase 3 trials, Cougar 301 and Cougar 302, and 301 was in the post-docetaxel. That's the screen that shows the prior docetaxel, and this now has been reported as a survival advantage. Okay, other data at ASCO were focused on the bone. Denosumab is a fully human antibody against rank ligand, or rankle. Rankle is a compound which, it's a kind of a complicated story. In effect, the cancer cells send out signals, sort of like a Pied Piper, and the bone cells follow this tune that the cancer cells whistle. And what that tune that the cancer cells whistle says, dissolve the bone, because I can use the bone to survive. It's a very complicated and sort of miraculous cycle. It's called the vicious cycle, because the cancer cells whistle the tune, the bones dissolve. That allows the cancer cells to survive in the bone. This antibody inhibits the ability of the bone to dissolve. And therefore, when the cancer cells whistles the tune, the bones don't hear it. At least theoretically, they don't hear it as much. So it's a pretty straightforward drug. It's given as a subcutaneous injection, very safe. And again, the compound in yellow was compared to Zolmeta, or zoledronic acid. How many here are on Zolmeta? Looks like a good number. Wow. Probably 20 to 50 of you. So this was directly compared to Zolmeta in a very large trial, 1,900 patients, 1-to-1 randomization. There we go. And although this was an advance, it was not a huge advance. There are some major reasons to think, though, that it's worth trying. First of all, it takes longer for the bones to be affected. The bones still ultimately get affected. Somehow the cancer cells learn to whistle a different tune, and the bones still are dissolved, but at a later and slower rate. And those measurements were quite precise. So we had a 20.7 month time for the first skeletal related event versus 17.1 months for Zolmeta. There was no survival advantage. It simply reduces the time to pain and the time to need for radiation. That having been said, there was also no real major side effect differences between these two, although most people who get zoledronic acid, in this case, not most, but a number of people who get zoledronic acid have two major side effects, like a fever chill side effect and a risk of kidney problems. In this case, the fever chill effect occurred in 18% of Zolmeta patients and only 8% of people getting the denosumab, and the kidney side effects were a little bit less, but not much. There was increased risk of osteonecrosis of the jaw, and that was not a major issue. So in this case, the denosumab, not yet FDA approved, is a potential treatment option for patients who have prostate cancer and bone metastases. It's not helpful for patients with metastases outside of the bone. And most patients have some side effects and will hopefully see this drug approved. One of the interesting things is that this drug, denosumab, works after Zolmeta or zoledronic acid are no longer effective. So we still have some ways to go. Now, wrapping it up with about 5 minutes to go. In the pre-chemotherapy treatment, we have a variety of other agents that are under phase 3 testing. We have the ipilimumab from Bristol Myers. That's an immune stimulator. That's a very potent stimulator. We have MDV 3100, which I mentioned. We have RAD, or radium-223. We have TAC 700. This drug is behind MDV, but is similar to MDV. And of course, anytime we have options, it may be somewhat better. There's another drug which I didn't mention called Zibotetan. It's from AstraZeneca. And it's like atrasentan, if any of you remember atrasentan. To improve docetaxel by itself, we have finished a trial of atrasentan. It's a pill once a day. Underway is another pill from Bristol Myers called dasatinib, which inhibits the SCR enzyme pathway. We are currently looking at Revlimid or lanalidomide. Lanalidomide or Revlimid has a major effect on myeloma, a bone cancer, and on MDS or myelodysplasia. And there's good logic to think that it would help improve the outcome in patients with prostate cancer and bone metastases. So we're studying that in a 1,000-patient trial. And then after docetaxel, you can see there's some of these drugs that are also being tested. There's a Canadian study called Custerson, a sunitinib trial that has been completed. That's a blood vessel antagonist. I'm not too optimistic about that. And then there's the other three that have already been mentioned. So to summarize, we have shown that adding bevacizumab does not help, but it does improve outcomes a bit. Weekly docetaxel should not be used. I just saw a patient last week who's been getting weekly docetaxel. Don't do it. Sipuleucel T is now FDA approved, thankfully, and we can now give it to most patients. The cabazitaxel is a major new therapy for second line, and we no longer have to fear the side effects of it because we have ways to get around it. Denosumab is not yet FDA approved, but we hope it will be shortly. And there are at least 10 other agents that are being studied in phase 3 trials. We ask you to join those trials, and if you're asked to join them, please volunteer. That's it. I have 1.5 minutes left to go. Mark, I finished on time. Thank you, Mark.
You get to stay up there. You get to stay up there for questions. You thought you could leave.
Uh-oh.
This is the hot seat. This is my favorite part of the conference. Okay, so let's cover a few things. Do you know why chemotherapy gets a bad rap? I'll tell you why chemotherapy gets a bad rap. It gets a bad rap because when the TV reports the impact of Taxotere that you work with, it says 2.5 months survival, and then you see a paper come out in a major journal several years later that says, oops, it might actually be 2.9 months. And then some of the oncologists and urologists jump up and down and go, isn't this great? And I think a lot of patients are going, how is this in advance? So I'm going to give you the opportunity to defend your colleagues when you hear 2.5 months survival, why I should get excited.
Oh, you want me to?
Oh yeah, no, you're going to represent all oncologists today in the world.
Okay, well.
Because I'm just putting myself in the patient's
it's fair.
situation. So if that's my dad or that's me, I'm frustrated.
Well, Mr. Moyad, the idea that you'll get 2.9 months extra life from docetaxel doesn't apply to you specifically. It applies to thousands of patients lumped together. For you, that benefit may be zero, but that benefit may be a year or more. And if you happen to be in the lucky group where it really works, you may get a substantial improvement in outcome. So I live in Las Vegas. I'd take that gamble.
So are you saying that some people actually have received Taxotere and been alive a few years later?
Indeed. I have a Filipino guy who's right now had cycle number 36 of docetaxel. And his cancer is, I just basically stopped it because I wanted to give him Provenge.
So I think that one of the mistakes we agree is that when the press reports a median survival, it's like going to a class and the teacher says, you know, the average was about a B, but people forget that there were a lot of A's in that class still, right?
Right.
And so
exactly.
That's what happens. So when I saw that initially too, what you actually go back on that trial is that a large number of patients, 3-4 years later, are actually still alive.
Right.
And I think we have to we have to do a better job of communicating that.
Yeah, it's hard. And it's the same thing, the same discussion occurs with cabazitaxel. You know, you go, it's 3 months, is that really worth it? But
right, so let me correct, before he makes a comment, that's the second chemotherapy that was approved this summer, and the trade name is called Jevtana, I think. And Jevtana reported 10 weeks extra, and the reason why no one picked up the story is they're going, 10 weeks? What kind of bullshit is this? So I'll let you finish your statement. I'm sorry. I just wanted to swear I wanted to swear like you did during your presentation.
Well, let me tell you. You know, sometime the best thing is just to tell the stories. You know, I love treating prostate cancer patients because they all have a story. You know, the California Highway Patrolman who arrested the Los Angeles mayor, and shortly thereafter got fired. You know, the World War II vet who managed to, a tail gunner in his plane, managed to shoot his own tail. You know, the bombardier who jumped out of a plane, B-24 over Italy and managed to fracture his skull and be alive to tell about it. But the stories inform the data. So Chester, who's an ex-Marine, has had 8 different chemotherapies. The guy is a Marine. I mean, he may be 80, but he's a Marine. And 8 different chemotherapies. He comes in, he's in excruciating pain. He's got a mass the size of a football in his abdomen. He's short of breath. His tumors are causing him to not be able to breathe. And I said, let's try cabazitaxel. I mean, you know, it's 9th chemotherapy. Goes, okay, let's do it. 6 weeks later, his PSA is down to 300. It was 1,000. His pain is 0 today. His shortness of breath is gone. The fluid in his chest is gone. His circulating tumor cells are dropping like a stone. So, you know, you don't know who's going to benefit. And it's for that reason that everyone should at least try it if you have cancer that's outside the confines of hormones.
So we have 2 chemotherapies approved for the situation he's talking about. One's Taxotere, the other one's called Jevtana. It's Jevtana. When I used to badmouth chemotherapy a lot more in the past, I didn't have my data straight, but I also learned from the trials that a lot of people look at someone, they think chemotherapy, hair loss, and fatigue, but in reality, some of the trials he's talking about, including Taxotere, correct me if I'm wrong, there was actually a quality of life benefit.
Right.
So even though it's associated with a lot of side effects, patients actually felt better. Pain went away. They actually did well. And again, I think this is a perception problem you have, and someone should do something about it.
Right. We should invent a new name for it rather than chemotherapy.
Right. So before I go to, I have one more question on chemotherapy. If chemotherapy works where it works, then why aren't we trying to give chemotherapy for men that have really, really aggressive early disease along with their regular treatments? Why aren't we doing that like we do in other cancers?
Well, that's a very good point. We've tried on a number of occasions. The VA has a trial underway that is going to finish, actually. It compares men with advanced prostate cancer given surgery, radiation, hormone therapy to surgery, radiation, hormone therapy, and chemotherapy. And that trial is coming fine. The patient I saw Friday afternoon walked in the door with obstruction, urinary blockage, and a PSA of 2,700 and lymph nodes and metastatic disease. He will go on to the trial that is called CHARTED. That's hormone therapy plus or minus chemotherapy. So we are trying to move the chemotherapy earlier. It's just taken a long time, and I don't know quite why that is.
But some doctors, I think, would give it early if the disease was really ugly, really bad.
Oh, yeah.
Right?
Oh, yeah. I mean, I presented the same story to somebody yesterday who had a Gleason 10. And he had positive margin, positive seminal vesicle, and one positive node. And I said, now, I understand that your surgeon told you not to just do anything but surgery and maybe hormones, but I said you really should think about whether you want to add chemotherapy there, because it would be another way to kill what microscopic cancer might be in your body. So it is logical. It doesn't necessarily have proof that it's going to work, but it's logical.
Okay, one more question on chemotherapy. Earlier this year, taxpayers paid for a trial in breast cancer that showed that 3 days before chemo starts, if you take ginger capsules and then take it 3 days after you receive chemotherapy, it can reduce nausea along with your prescription medications by as much as 40%. Are people using that since that data just came out? Are you using that? Are you intrigued by that? What do you think about it?
Well, the value, when I was at University of Chicago, we started up a program in complementary and alternative medicine. And Dr. Yuan was in charge of that. And I'm a firm believer that we have yet to find many other compounds that are useful. Ginger is a good example. And so I do tell my folks to drink ginger root extract. It's not like it's going to be painful to do that. So yes, the answer is there's all these little tricks that we can use to reduce the side effects of treatment, and some of the herbal and botanical medicines are going to be useful. I think we have yet to scratch the surface. The Japanese sea sponge just got reduced to a compound that improves the outcome of breast cancer after extensive prior chemotherapy. That just got reported this year. So we're nowhere near the end of our ability to find new drugs.
So you also came here and announced this big finding that abiraterone, which is a pill, and it's made by the Johnson & Johnson company. Basically, Johnson & Johnson took over for Cougar, right?
Right.
So what does that mean to the audience? Who's going to be eligible for that pill?
Well, this past week, those of us who were participating in 301, that's the post-docetaxel abiraterone trial, have to now go to some god-awful training program and describe how we are going to inform our patients who were on the trial that they now can get the free drug, the crossover. That will hopefully happen. In addition, J&J is instituting a rapid a program for access to the drug. It's called an expanded access program, and we're scrambling to put that into place. It will be a registration program where you have to sign a consent, and J&J will have to track the people in it, and we will have a certain reporting responsibility, and we will have the FDA looking over our shoulders. But other than that, the drug should be available, I would imagine, within the next 5 to 6 weeks.
Wow, okay. And what do you think about our Provenge petition?
Go for it. I've been fortunate that most of my patients have gotten their insurance to approve it. Although Aetna turned down one of my patients, they said the patient had visceral metastases, which was an exclusion criteria in the clinical trial. So suddenly the insurance companies are becoming scientists, which is really ironic. I told my patient, well, just get a lawyer and it'll make that go away. Or get a scientist. But that's been generally insurance approved. I haven't had any trouble yet.
Okay, great. Just a few more, and then we'll move on. You talked about Zometa, that all these people had in the audience, but what you were alluding to was that earlier this year in a head-to-head study of this antibody, which is now known by a trade name, we don't know if this is going to be the trade name, it's called Prolia,
Yeah.
right? So Prolia went up against Zometa in this phase 3 trial and beat it.
Right.
So why isn't the drug approved? Where is it? Why can't, if I want to now get that as my bone drug and I have prostate cancer and I want to come off Zometa, or I don't want Zometa, I want the new one that beat Zometa, where is it? What's going on?
Well, I have to be a little cautious because I'm on what's called the DMSB, Data Monitoring Safety Board for Amgen. And I have, along with some of my colleagues, have been asked to look at the entire Prolia portfolio, including breast cancer, prostate cancer, osteoporosis, bone prevention, myeloma, giant cell tumor of the bone, etc. They have, in brief, I think they have a lot of irons in the fire, and they're trying to get this Prolia approved in a lot of different areas, and I think they may have it approved in osteoporosis. And so it's approved in osteoporosis, but it's not approved yet in prostate cancer, breast cancer, and other diseases.
Right, which is the crazy part, right?
Right.
Right, so we agree that's crazy, but I think the lesson for today is Zometa got beat in a head-to-head trial. Zometa's a good drug, but if you are being asked to go on a bone drug, make sure you just ask what the status is of Prolia and where it is, and can I get it, or what's better for me, Zometa? I'm not saying Zometa is still not an adequate drug. It's just that people should know that we just had that new trial.
Right.
My last two questions, and then remember, all speakers get to go in the room across the hallway, and you can ask them questions because it's very complex. It's a lot of information. Best restaurant in Vegas, in your opinion? You only get one choice. You can't do the politically correct thing and mention two. You're on tape.
Where I Took You.
Yes, right. What was the name of that?
A place called Vintner's Grill.
Vintner's Grill. That place was fantastic. You know what the best
Vintner's
part
Grill.
about it was? You paid. That was the best part. The second question is, before I let you go, best show in Vegas right now. What's the best show?
I love Jersey Boys.
Okay. There we go. So, Dr. Vogelzang, thanks so much. He'll be across the way, and outstanding. Thank you. I appreciate it.
You're welcome.